R.A.T.S. Racing Against Time for Students in Pathology. In this session, I have got a couple of small topics which shall be easy for us to cover. One is a Pheochromocytoma. The importance is given here. A number of subjects, including pathology and surgery, cover this one. These are the subheadings under which anyone should answer, even if it is going to be a short topic. And in the adrenal, there is a fleshy reddish brown tumor, which can be a pheochromocytoma, well circumscribed. The word pheo is derived from a Greek word meaning dark, and cyto is cell. Chroma means it resembles the chromophene cells or the chlorophyll, and homo obviously means tumor. And this particular tumor, the pheochromocytoma, was identified by Ludwig Pick, a German pathologist. And the color is the reason for the term pheochromocytoma. Look at this particular specimen. I am able to make out the bean-shaped appearance of the kidney, and it has been cut open. In the upper pole, the adrenal is almost totally replaced by a hemorrhagic reddish brown tumor. So it is a tumor of the adrenal medulla. A similar tumor can also occur elsewhere where it is called paraganglioma. The patient presents with three classical symptoms or 3 P's, namely palpitation, perspiration, pain in the head or headache. That can be because of a hypertension. A couple of diagrams which you people shall and will draw. It is a cut open specimen of the adrenal in which there is a well circumscribed tumor in the medulla. So this is the medulla, this is the tumor over here, and externally there is a cortex. So the tumor is confined to the adrenal medulla. Lower down is the kidney. So this is one, a pheochromocytoma of the adrenal medulla. The other picture, it shows a Y-shaped bifurcation of the carotid artery amidst which there is a tumor. So they say that it occurs astride the bifurcation of the carotid arteries. And this is a linear section of the same. There are the two carotid arteries in between which there is a tumor. Very simple diagram which will fetch you marks. And it is a tumor that arises from the sympathetic trunk. One is the carotid bifurcation we had mentioned earlier, but it can occur elsewhere. For example, the organ of Zuckerkandl, urinary bladder, adrenal medulla, sympathetic trunk, etc. So please mention all this. It is a university question for you in surgery also, and all these will be having an identical histological picture. So what are the adrenal sites? What are the extra adrenal sites you people should mention? Rule of 10, a golden rule that has stood the test of time. 10% of the tumors are extra adrenal, 10% bilateral, 10% familial, 10% occur in children, 10% are malignant, 10% are associated with men, multiple endocrine neoplasia, and 10% of the patients clinically present with stroke. Rule of 10, please by heart, it will definitely pay you dividend. This is a little complex but not as difficult as we think. I find that there is a cluster of cells. The tumor cells are placed in clusters. It has got a definite pattern which is called an organoid pattern. Organoid pattern. The cells are large and polygonal. Each one is a cell. It is large and polygonal. The darker one appearing one is the nucleus. And it is more or less uniform. Whether you see the upper half of the lower half right side or left side, it is more or less similar. And the cells are arranged in nests. Look at this one, there is a nest of cells. Again, another nest of cells. Anywhere, here again I am finding a nest of cells. And they are all separated by, the white arrow is pointing out to it, slender septae which have got the blood vessels. So it does not have any ducts. All the secretions are directly outpoured into the blood. This particular pattern of appearance is called an organoid pattern or a Zell-Ballen pattern of appearance of the tumor cells. This will be asked as an MCQ and you will have to mention it in your theory answer as well. So once again I repeat it, there is a Zell-Ballen appearance. This is a much better picture where I am able to see the multiple circumscribed lesions which are separated by slender septae and they all have the RBCs. So they are all slender capillaries. So blood vessels are over here, a Zell-Ballen pattern. Draw this. There is an entity called a malignant pheochromocytoma. Look at this particular one when compared to the others. I am finding a large nucleus, irregular nucleus. This appears to be multinucleated. And this also is large and irregular when compared to its counterpart. So there is pleomorphism of the cells. Some cells are large, some are small. Mitosis can be present. But the definite criteria for malignancy will be metastasis. Without metastasis, we cannot make a diagnosis of malignant pheochromocytoma. The classical features I had mentioned: palpitation, perspiration, pain in the head. And for diagnosis, there can be an excretion of catecholamines and the urinary excretion of phenyl mandelic acid, VMA. Clinical presentation with hypertension. So this is a summary. I would like you people to kindly by heart this particular column. It occurs mostly in the adults. 10% can occur in children. And you find that 90% are benign, 10% are malignant. Urinary levels of catecholamines and norepinephrine in the blood can be increased. Clinical presentation will be all the features that we had mentioned. Glycosuria also can be there. And macroscopically, you find that it is a hemorrhagic mass confined to the adrenal medulla. 10% of it can be bilateral. 10% is extra-adrenal. Microscopic features are large nests of cells called as Zell-Ballen pattern and separating vascular stroma. The next one is an introduction to thyroid neoplasm part 1. So this is a usually asked question, but the students tend to omit because it is somewhere towards the end and we think it is not important, but the importance is given in the enclosure. Any particular group of tumors classify, and this is one of the easiest classifications for us. The thyroid tumors can be divided into benign tumors and malignant tumors, and benign is an adenoma. Adenoma, there is only a follicular adenoma. R.A.T.S is a variant of follicular adenoma. Malignant on the counterpart, you find that there can be a papillary carcinoma, follicular carcinoma, R.A.T.S cell carcinoma. All of these can be well differentiated. Well differentiated means resembling the cell of origin. Undifferentiated means not resembling. Under that we will be having anaplastic. And the last group will be the medullary carcinoma. It arises from the C cells. So the tumors of the thyroid, benign and malignant. Benign is follicular. Malignant, it can be papillary, follicular, and R.A.T.S cell. The undifferentiated tumors are anaplastic in appearance and medullary carcinoma thyroid. So very small classification, please by heart. The papillary carcinoma of thyroid I shall be dealing with. So this is a normal thyroid over here, and when they cut it open, they find that there is an enclosure that is having multiple small, delicate papillary excrescences. Very delicate, grayish white in color, very well circumscribed. So this is the appearance of a papillary carcinoma. It is associated with radiation. Earlier, the patients used to undergo radiation for persistent thymus, and they ended up developing a papillary carcinoma of thyroid. The second nature can be an accidental. The Chernobyl disaster is a classical example where many people develop papillary carcinoma. It can be solitary, it can be multifocal. It is usually well circumscribed. Sometimes it is only microscopic in appearance and incidentally identified. Delicate papillary excrescences, and it can sometimes infiltrate into the adjoining structures of the thyroid. This is a very important picture. It can be a slide for you also. I am finding it is a cut surface of a papillary process. Central fibrovascular core, surrounding which there are cuboidal or columnar cells, and there are large nuclei. All the white appearing spaces are empty looking nuclei, which are called the orphan anine nuclei. Orphan anine nuclei, it's a classical character which you should remember. Coming to the papillary processes, they are branching and rebranching, arboriform or tree-like in appearance. There is one variant of a papillary carcinoma called follicular variant of papillary carcinoma. Please remember this. Orphan anine nucleus, it is definitely an MCQ. Arboriform pattern, papillary pattern, MCQ. Apart from that, there can be a ground glass appearance of the nucleus, orphan anine nucleus. There can be a nuclear grooving. Look at the nucleus over here. It has got somewhat a coffee bean like appearance. A nuclear grooving can be there, and sometimes this is not a nucleolus, it is an inclusion within the nucleus, which we call as pseudonuclear inclusions. Pseudonuclear inclusions. Psammoma bodies. In the papillary processes, there can be concentric depositions of calcium, an example of a metastatic calcification. This is called a psammoma body. The tumor can metastasize to the regional lymph nodes, or sometimes there can be distant metastasis. Generally, compared to the follicular counterpart, it has got a better prognosis, particularly in younger patients. The treatment for it will be near total thyroidectomy, chemotherapy, and radiotherapy. Before I complete, I will just mention these are all psammoma bodies. As I mentioned, there are concentric deposits of iron and calcium. So this will be seen not only in a case of papillary carcinoma, but also in a meningioma. In fact, this particular slide is a meningioma of the brain. Another tumor where you can get it is the papillary serous tumor of the ovary. These can fetch you marks as a differential histological diagnosis, and also it can be part of an MCQ. Gracias.